For this video, we will not be focusing on the antivirals used in the treatment of viral hepatitis, and we'll save this discussion for a later block. Instead, we will be focusing on how reduced liver function and/or liver damage can impact drug pharmacokinetics. And this will be an important introduction that will be built upon in pharmacology in Block 4. So there are three main pharmacokinetic factors that can be impacted by liver function. And that is metabolic enzyme capacity, which I'm showing you here, plasma protein binding, and the last one is hepatic blood flow. Now, drugs can be grouped based on which of these factors impact their pharmacokinetics. And a hint for Block 4 is drugs will not be affected by all three of these together at the same time. But we will leave these nuances for Block 4, and we just want to start building the foundation for today and introducing these concepts. So starting with metabolic enzyme capacity. So we've already discussed how once drugs are administered, the majority will travel to the liver, which is the primary site for drug metabolism. Once in the liver, drugs are metabolized by a slew of enzymes, like the CYP450 enzymes we've talked some about in previous videos. And the drugs are then converted to a variety of metabolites. And these drug metabolites can either be active or inactive. So now, if the metabolite is active, then the liver converts the drug that is administered, which is a prodrug, which I mentioned this term prodrug before, and just remember it is a biologically inactive compound, or a significantly less active compound. And this prodrug has to be converted to its active form, which can then leave the liver to be carried to its site of action to elicit its effects, and then eventually be excreted by the kidney, which is usually the site of excretion for most drugs. So for example, the first prodrug I always think of is codeine, which is converted to morphine by the enzyme CYP2D6. And morphine is 14 times as potent as codeine. And then once codeine has been converted to morphine as the active metabolite, it can then travel to interact with mu-opioid receptors to trigger the analgesic effects. Now, if for some reason there is reduced liver function or liver damage, this means that there is also reduced function and or loss of metabolic enzymes in the hepatic location of the injury. Therefore, the metabolic enzyme capacity is reduced. So if you are administering a prodrug in this situation, then less prodrug is going to be converted to the active form. So the patient may not experience the therapeutic effects of the drug. So for example, for codeine, the patient may not experience adequate pain relief. So now let's talk about the other example where the metabolite is inactive. And this is typically what people think of, where the drug is administered in its active form, where it reaches the liver to interact with enzymes to then be converted to an inactive metabolite, which will then leave the liver, not elicit any effects at its target, and be excreted from the body by the kidneys. For this case, we will use warfarin as our example. So warfarin is administered as an active drug, but after metabolism via CYP2C9, it is converted to a hydroxylated inactive metabolite to stop any further anticoagulant effects and be excreted from the body. However, in the setting of liver damage or dysfunction, warfarin will not be metabolized as well, and more warfarin will hang around for longer, leading to a patient who is supra-anticoagulated and at a significant risk of bleeding. These are two ways in which reduced liver function can affect metabolic enzyme capacity in the liver and a drug's pharmacokinetics. So moving on to the next slide. Now we will discuss how liver damage and dysfunction can affect plasma protein binding. So there are a lot of different plasma proteins, but the two most important ones for drug binding are albumin and alpha-1 acid glycoprotein, which is normally abbreviated as AAG. And both of these plasma proteins are produced in the liver. And a lot of times albumin levels can be used as a readout for liver function. So as we talked about before, drugs are almost always either a weak base or a weak acid. So albumin is basic, so it will bind weakly acidic drugs, whereas alpha-1 acid glycoprotein is acidic and will bind the weakly basic drugs. Now, drugs bind to plasma proteins at varying degrees, and this is based on their affinity for that plasma protein and their lipophilicity. aka how much does the drug need help being shuttled around in the blood. But an important takeaway is that free or unbound drug is able to elicit therapeutic and toxic effects. It is able to be metabolized and be excreted, whereas bound drug is sort of protected from removal from the body by that protein, but it also can't elicit any effects and bind its target receptors. So based on a drug's percent of protein binding, we can determine if changes in protein binding will actually influence a drug's pharmacokinetics. So if a drug is anywhere from 0 to 50% protein bound, then any changes in plasma protein binding will result in negligible effects on the drug's pharmacokinetics. So if we change plasma protein binding because of liver damage and disease, it's not going to affect the drug's PK with regard to protein binding. If a drug is anywhere from 50 to 90% bound, this is designated as moderate protein binding, and this may or may not affect things to a significant amount. But if any drug is more than 90% bound to plasma protein, changes in protein binding are much more likely to influence the drug's pharmacokinetics and alter them. So we would be concerned in this case of liver disease and damage altering those plasma protein levels. So I will provide an example to show you why this is the case. Let's say we have a drug that is only 50% bound to plasma protein albumin, and it's 50% unbound and active. But the patient suffers liver damage for whatever reason, so there is a drop in albumin. So now only 45% of the drug is bound, and 55% of the drug is now unbound, free, and active. This is only an increase in free or unbound drug by a total of 10%, because it increases by 5%. We started at 50 and now we're at 55. And a 10% increase really isn't much and is probably not going to lead to an increase in drug concentration to the level to trigger toxic effects, and will likely be within normal limits. Now let's compare this with drug B, which is 95% bound to plasma protein albumin, and only 5% of drug is actually unbound and free and able to elicit effects. But now let's say this patient suffers a similar degree of liver damage, so there is a comparable drop in albumin. So now only 90% of the drug is bound, and now 10% of the drug is unbound. So this is still only an increase in 5%. However, in the case of drug B, this now means that the amount of unbound and active drug in circulation has essentially doubled and increased by 100%. So now twice as much drug is hanging around to trigger effects. But remember, this also means that more drug is free to be metabolized by the liver. But remember, it is in the setting of liver damage. So it's likely that metabolism of the drug is reduced too. So not only is twice as much drug hanging around, it's hanging around for longer. And if this drug has a narrow therapeutic window, which I won't get too much into today, it basically means that the therapeutic concentration is not far off from the toxic concentration. So there's a very small window of concentrations where you can get therapeutic effects without toxic effects. And this doubling of free drug could be an issue for the patient. So in the setting of highly bound drugs and liver damage, there may be a concern that the increase in unbound free active drug can trigger toxic effects. So understanding the relationship between plasma protein binding and drug binding and liver function is an important pharmacokinetic consideration. So moving on to the next slide. Our last factor we will discuss is hepatic blood flow. So now hepatic blood flow will deliver drug that has been absorbed from the gut before it is sent out to the rest of the body. And this is the case for orally administered drugs. And now once this drug is sent out to the body, it can elicit its effects and then return to the liver to be metabolized and eventually excreted by the kidneys, for example. Well, as you can imagine, reductions in liver blood flow can alter how drug is metabolized and delivered to the liver. But this is where there's a lot of nuance that I mentioned before. And this will be sort of drug specific. Some drugs, when they are given orally, they will travel to the liver first after being absorbed, and liver blood flow will dictate the time the drug actually takes to travel through the liver and be acted on by the enzymes in the liver before it's sent out to the body. If this blood flow is reduced because of liver dysfunction, then the drug will take even longer to traverse the liver, giving it more time to potentially be metabolized by enzymes before traveling through the body. If the liver damage effects on enzyme function is negligible. So this would lead to less drug reaching the body and a lack of efficacy for the patient. For some drugs, this won't necessarily matter for, but if you reduce liver blood flow, it may reduce the drug's ability to travel back to the liver to be metabolized. So if this matters for a particular drug, there could be a backup of drug trying to enter the liver to be cleared, but reduced liver blood flow reduces this rate of clearance. So the drug builds up in the circulation, waiting to enter the liver, leading to the risk of elevated drug levels and toxic effects. And lastly, if liver damage is significant enough in which a shunt is required to redirect blood flow in the liver, any drug traveling through the shunt will not be taking its normal path through the liver to be metabolized and can also lead to increased drug levels and potentially toxic effects. So a drug's pharmacokinetics can be significantly impacted by liver disease through metabolic enzyme capacity, plasma protein binding, and hepatic blood flow. And though there will be a lot of nuances with different drugs, these are important factors to become familiar with when looking at a drug's metabolism and drug-disease interactions, specifically with regard to liver disease.